Good afternoon and welcome everyone to July's Fireside Chat in recognition of Bone Cancer Awareness Month. I'm Amna Hussein, the Community Outreach and Engagement Manager at the Masonic Cancer Center at the University of Minnesota, and I have the privilege of serving as your host and moderator for our Fireside Chats each month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. Our office serves as a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our small but mighty team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. As mentioned, July is Bone Cancer Awareness Month, a time to elevate awareness about a disease that can affect people across all ages and walks of life. While bone cancer doesn't receive the same level of attention as some of the more common cancers, its impact on individuals and families can be just as profound. And that's why conversations like today are so important and why we are so honored to be joined by Dr. Reza Talaie, whose work exemplifies the very best of compassionate care, academic leadership, and cutting-edge research. Dr. Talaie wears many hats at the University of Minnesota. He is an associate professor in the Department of Radiology. He's also the program director of the interventional radiology residency program in the medical school here at the university, and is a practicing interventional radiologist with a deep commitment to patient-centered care. In addition to his clinical work, Dr. Talaie's research focuses on the treatment of bone cancer and myeloma-related bone lesions. Beyond the clinic and lab, Dr. Talaie is recognized for his leadership and excellence. He, in fact, was named a top doctor by Minnesota Monthly in 2024, a recognition of his outstanding care and the respect he's earned among his peers and patients. We're truly honored to have him with us today to guide us through this important conversation on bone cancer care, treatment, and research. But before we dive in, I'm going to cover just a few quick housekeeping items. We do record the Fireside Chat, and the recordings are always available on the Masonic Cancer Center's YouTube page. For any University of Minnesota employee or spouse participating in the university's employee wellbeing program, you can earn 200 wellbeing points by completing the form that is linked in the chat. Please make sure to use the Q&A feature at the bottom of the Zoom screen to submit any questions or comments you have throughout the session today. We promise we have time carved out at the end for a Q&A session with Dr. Talaie. And without further ado, I'm going to pass the virtual floor over to Dr. Talaie. Dr. Talaie, thank you so much for being here with us today. And the virtual floor is all yours.
In terms of understanding the bone cancer, it has to be understood that there are two main types, primary and metastatic bone cancer. They both can be quite significant and symptomatic and consequential, but the difference is that when it's primary bone cancer, it originates from the tissues that are involving the bone. And then more frequently, a bone is a target, a place that because of a multitude of reasons, the way that blood flows through it, the way that, the immune system works, interacts with it, the way it has its own, rejuvenation process. It's a common target for metastatic deposit from other cancers. Those frequently come from very, known and frequent cancers. Breast cancer, prostate cancer, lung cancer, and kidney cancer are some of the most frequent, offenders here that involve the bones. And the typical sites for the bone cancer, whether primary or metastatic, are spine, pelvis, the femurs, and the ribs. It doesn't mean that the humerus or the forearm, for example, can't be affected by it, but these are the more common sites. What are some of the most frequent symptoms that patients with uh, uh, these type of cancers can experience? Obviously, pain, unexplained pain, not frequently associated with big trauma, minor trauma that lingers around for a very long time. It's unexplainable. Why would somebody have this degree of pain? And sometimes without any trauma, without any preceding trauma. When somebody has a minor trauma and the pain and lasts beyond the expected range or is disproportionate, essentially, investigation should start into the cause of that. Not all of them are related to cancer, but that's one of the hallmarks of these essentially cancers. Fractures that are, again, what we call, pathological fractures. When a fracture is associated with healthy, normal bone, we call them fractures or traumatic fractures and whatnot. But once they result from presence of a pathology in the bone, in this case cancer, we call them pathological fractures. Again, frequently these are associated with not very high impact, again, unexpected fractures. Weakness, difficulty in mobility are some of the others, essentially, symptoms of these cancers. I want to focus a little bit more on the metastatic aspect of the bone cancer or cancer in bone. It should be understood that 60 to 80% of patients that suffer malignancies end up with some bony involvement. So that's a very common pathway for a lot of cancers that eventually involve the bones. It's actually the third most common metastatic location in our body. So it's very common that people who start to gain ground on the cancer, essentially they survive longer. Eventually they deal with this essentially common problem that faces them down the road. As we have succeeded more and more in prolonging the survivorship with the cancer, we are seeing more consequences of it, and this is one of them. Most commonly, the axial skeleton is affected by it. The axial skeleton, as opposed to the appendicular skeleton, is what carries our weight at the center of our body, the spine, the pelvis, that's where most of these metastases happen. And I have a number at the bottom. You can see that, the most common site for metastatic disease is the spine. And then second to that would be the pelvis. Obviously, the appendicular skeleton, the limbs can also be affected. As you can see that you can have up to 25% involvement in the femurs. The things that happens once either with the primary or secondary bone cancer, the quality of life degrades, the pain increases, and morbidities such as fracture can happen. So what is it that we can do about them? So one of the things that can be done for all these cancers are systemic therapies, okay? Ideally, we would like to catch them at a stage that they're very limited. There's only one or two of these metastases, or something local can be done about them, such as excision that can be done with surgery, such as image-guided treatments, which is something that I do, such as radiation, but not infrequently, these cancers have already metastatized or are a result of metastasis into the bone and are an indication that a systemic treatment has to be done, okay? So not infrequently, doing a local treatment is a complete cure for it. Essentially, to treat these with curative intent is a rarity. Frequently, particularly when we're talking about metastatic disease, you have to combine that with systemic therapy. And that's one of the reasons that, any of those local treatments that, can reduce the symptoms, but don't cause stoppage in the systemic treatments that are the mainstay of treatments for many of these patients are very, very invaluable. So one of the issues with surgery is that, yes, you can do an operative treatment for some of these, but if it results in a stoppage of immunotherapy or chemotherapy or whatever other systemic therapy treatment they're getting, for example, to allow for wound healing to happen, that's a setback. So we want to make sure that we only use something like surgery if we absolutely have to, in terms of our local treatments. The goals of these treatments, regardless of systemic or local, is to control the pain, So pain management becomes a big part of, living with cancer. And as a result, a lot of specialists have a role in this journey. People who are focused on comprehensive pain control, physical medicine and rehabilitation doctors, pain specialists, palliative doctors. There are a whole host of, players in that aspect of treatment. But also, some of the stuff that we do in interventional radiology can play a role in control of the pain and some of the other mentioned treatments. Our ultimate goal is to improve daily functioning and quality of life, decrease the skeletal and neurological events, things that can start with a smaller metastatic deposit. If it's unattended, eventually can result in a fracture. And if it's, say, in the spine, that can compromise the spinal cord and otherwise. So stabilizing the skeleton becomes important. And obviously, we always have an eye on, local tumor control. Again, particularly if we're dealing with very few metastatic deposits, that's even more important. One of the things I'm frequently asked is what is interventional radiology or vascular interventional radiology? I have different types of answers that I give, but in all seriousness, it's a minimally invasive line of treatment that uses image guidance. If I were to explain it to you, essentially, all I do, I've spent many, many years of my life, but to only hone two sets of skills, okay? One is to get directly to any part of the body through the skin, say the bone or the liver or the kidney or the lung or what have you. And that is to drive that needle from the skin after obviously we numb the patient up and everything, or sometimes use sedation or general anesthesia, but to drive that needle using the image guidance. And there is all sorts of imaging that I can use. We can use CT, we can use MRI, we can use ultrasound, X-ray or fluoroscopy to navigate these needles with two goals: to hit the target, but to avoid everything between us and the target that needs to be avoided. So it's a very, satisfying, essentially, line of work, because it allows many things that in the past were assumed impossible or required big surgeries to avoid those things. Essentially, you don't even make a real incision. You just drive a needle into the target. That's skill number one that an interventional radiologist should have. Skill number two is to navigate through blood vessels, okay? So that's vascular, that's hence the vascular part of it. We navigate through all sorts of vessels in the body, essentially arteries, veins, lymphatics, okay? And find our way to a particular destination, navigating inside the blood vessels. The thing that can happen as a result, particularly about the cancer care, is that we can deliver treatments either through that needle or through this navigating our way inside the blood vessels and getting there. For example, most of patients who have had liver cancer have dealt with one of us, because it's one of the main ways, or probably more common ways, of treating liver cancer before it gets kind of out of hand and requires systemic treatment before it becomes metastatic or too diffuse, is to essentially go through blood vessels, find the blood vessels supplying that cancer, and deliver treatment. And similar things can be done and are being experimented with in other areas, okay? So essentially one of the two ways of getting there, either directly through the skin or navigating through blood vessels and delivering the treatment that needs to be delivered. One of the main advantages of not making a big cut, yet again doing something local regional, right, is to discharge the patient the same day, almost always. Very rarely we keep the patient in house for 1 day, and that is an important facet of it, For example, if somebody has a kidney cancer, right, or in this case, bone cancer, if there's involvement of the vertebra, okay? If I can advance a needle there, deliver the energy, kill the cancer, fill up the hole that I create with some cement and take the needle out, there is no reason for that patient to stay in the hospital for more than 1 or 2 hours, and that's exactly what happens. Many of our patients get discharged the same day versus if I were to do a big surgery like a complectomy, essentially remove that vertebra and then put hardware and stuff like that. And that is going to be needed sometimes. But if we are not doing that all the time, that's what I'm trying to say. And in the cases that we can get away with doing the minimally invasive treatment, that's going to be a significant advantage for the patient because patients don't have to spend time in the hospital. And just as important is that they continue to get their systemic treatment. That's another facet that is particularly important about what we do in interventional radiology. So let's look at some cases, okay? So this is a patient with hepatocellular carcinoma, essentially a fracture you can see in one of the vertebrae, as you can see in the bone, L5 vertebra is fractured. After having a deposit from the cancer. So we have proven that this is cancer in the bone, and now we're dealing with the consequence of it. As you can see, the vertebral column levels above it, they all look like squares with some edges, with some degenerative changes, but none of them look like this, okay? So that dumbbell shape, essentially that compression deformity is an indication that there is no strength left in this vertebra. And what are the options here, right? So one is just to radiate this, for example, okay? And that can be a consideration, and it can be done in a few days or sometimes weeks, and eventually some pain relief happens, And the other option is to do a bigger surgery here, and again, not that anybody would necessarily recommend that, but hypothetically speaking, a surgery can be an option. The last option or the other option is to, go ahead and try to do something minimally invasive. And that's, what I'm about to show. And this is a very significant fracture for this patient. Patient is having very severe pain and is unable to sleep most of the night due to pain that wakes them up. And that is one of the hallmarks of, cancer-related bone pain, It's not just mechanical, mechanical pain, if somebody, God forbid, fractures their, arm or forearm, once you put a cast around it, it doesn't really, or if you don't move it, for example, it shouldn't cause as much pain. But the cancer pain, because of the inflammation associated with it, wakes the patient up at night, despite the fact that there is really no motion, no mechanical stressor. And that's one of the differences between that and mechanical pain we described the other one as. This is what we did for this patient. Essentially, we access that level with 2 cannulae. That's all it takes. Essentially, 2 cannulae goes in, we go in, create holes, go with essentially these probes that are able to release radio frequency energy. It's heat, essentially, that it's going to be spread. Then you can see we inflate 2 balloons in the area and inject cement in, and now you can see we have somewhat recreated the vertebra. It's imperfect, but let's look at the outcome for this patient. Patient had some post-op pain, expected a few hours afterward. That was managed with some IV and oral pain meds and was discharged home the same day. The second day after operation, they were only using half of their narcotics, which is a significant improvement for those who are using these medications. for pain control. They know how much they actually degrade their mental sharpness and how much they can interact with others. So, and they were very happy because they could sleep at night. So this is one example of tumor ablation. Okay, there are many things that can be done for these, as I said, but I'm going to focus a little bit on what you know, University of Minnesota IR is offering. One of the techniques that we use is called tumor ablation, and it's not specific only to bone cancer, but it's used for a lot of cancers, but it has a tremendous utility in treatment of bone cancers. It essentially uses different types of energy, okay? And the most common ones are heat or freezing. So those are the most common ones, but there are other types of energy that we can also use, and we do use them, but I'm just going to stick to the more common scenarios, okay? So when we talk about heat, it's either radio frequency or microwave, and freeze is like cryoablation. These are very ideal for painful or inaccessible bone lesions, okay? In this example, this patient would have lost a fair amount of time had we decided to do a bigger surgery for them from receiving their actual treatment, which was the systemic treatment for the cancer. So this technique gives us access, to those lesions, particularly if they're painful. The pain response to these treatments are fairly immediate. One of the largest series that was performed on bone ablation for painful bony metastases showed that 90+% of the patients had about 2 to 3 point reduction in the severity of their pain within only 2 to 3 days. They have their own advantages and disadvantages. One of the interesting parts about cryoablation is that it allows us to actually see the ice ball, which is harder to see in the bone, but overall is one of the perks of whenever you're doing it. It's just we have a lot of calculation to exactly predict how the ablation zone works. But with the cryoablation, there's a benefit in that you can actually see it, when you're using a CT scanner or ultrasound to image it live. Other things that we can do, one of them is to inject cement, okay? So there are different types of cement injection, different hardwares that we can deploy, but these are some of the most common hardwares that we do deploy, particularly when it comes to the spine, we have a very significant role. Again, as I said, spine is a very common place for metastatic disease to happen and for some of the primary bone cancers. For those, one of the things that we can do is not only we can go ahead and ablate them, we can give back the stability of the spine and relieve the pain that way, One thing that has to be understood is the fact that if there is impaction essentially in the way that a bone is enduring trauma, cement is a very good solution. But if there's torquing, for example, in the long bones, this probably is not as good. In those cases, you probably want some rod or some nail that our orthopedic colleagues are well capable of placement of those. You need an addition, something more than just the cement, because the trauma that the bone is experiencing is not just impaction. There's torquing around it, and that requires additional, augmentation with the rods or screws and plates and otherwise. But when we inject cement for indications that I mentioned, such as in the spinal column, the pain relief is nearly immediate, very, very imminent. It can take up to a day or two, but very frequently it's like a patient that has a fractured, forearm. If you put a cast around that, that cement performs as that cast. The piece of that bone no longer move. If it's in the spine, although it's an injection, because it's a polymer that is going to spread in the bone, it very effectively connects the pieces of the bone that are still there and prevents pieces from moving, essentially relieves the pain quite significantly and immediately. And then the additional benefit is the mobility improvement. What else can we do for these patients? Another thing that we can do, and this can be done in anticipation of some of the things that we do and or some of the things a surgeon can do. For example, somebody who has a very vascular tumor, a surgery for them can be a very dangerous surgery. Say somebody has renal cell carcinoma, cancer of the kidney that has metastatized to the pelvis. The surgeon is going to go ahead and extract that and do a hip replacement for that patient. Yes, that if we get past the part of removing the cancer and putting the replaced hip in there, that would be pretty straightforward. But the removing the cancer, this is a very vascular tumor. One of the things that we do in interventional radiology, again, we navigate through blood vessels, find the vessels that supply the tumor and block them with tiny little beads that or liquids, or sometimes with mechanical devices such as coils, okay? So all those devices are used to significantly reduce the vascular supply to these tumors, you know. It sometimes results in shrinkage of the tumors, but also makes things like surgery or ablation, that is what I'm going to do, quite a bit safer. So a lot of people, they do these kind of embolizations in anticipation of other procedures. There are studies that suggest that in cases that are not candidate for ablation or surgery or radiation, just pure embolization can also have some pain benefits, but that would be more of a last resort, okay? We have many other things that typically we can offer these patients before we want to do embolization as a destination treatment. But as a combo, as something that we do prior to, you know, ablation or surgery, that's a very effective treatment. Essentially, we go in through blood vessels, specifically find the blood vessel that goes to the tumor and release those through tiny little catheters inside the blood vessel. We release those little beads or the liquids or form coils to deprive that area of the tumor of the blood flow and reduce the chance of bleeding. Sometimes we do that to stop the bleeding in a case that there's no other surgery plan, but we want patient to stop bleeding so they can potentially be discharged home or things like that. Stabilization, image-guided stabilization. A lot of this is done by my orthopedic oncology colleagues, but that also because it also uses a fair bit of imaging, you know, it's something that I thought it would be worth mentioning. Not all surgical procedures are going to be open and with big incisions. A lot of surgeries, modern day surgeries, that we participate in them too as part of it, but a lot of it is done by the orthopedic oncologist. They can do the screws that I mentioned, for example, for the hip, for the long bones, stuff like that. That can be done. And then that can be combined with ablation and cement injection. Frequently, actually, I cooperate with one or two of my orthopedic oncology colleagues, and I do the ablation and cement injection part, and they do the screw fixation part. But that can also be done only with image guidance. We really don't open the leg, we don't open the pelvis, just enough to get the device in. And again, that is being done with image guidance. And the benefit of this, again, is the fact that patient can be discharged nearly immediately, usually with a day or two of delay, and there is no real stoppage of systemic therapy for any reason. I'm going to show you one more case, and hopefully after that, I'm going to go kind of wrap it up and kind of answer any questions that you might have, either about the primary bone tumors or secondary metastatic bone tumor. This is a case of a 65-year-old female with diffusely metastatic breast cancer. As you're looking at these bones, none of them look very healthy. All these sclerotic changes are a result of, you know, of previous treatment. It doesn't mean that there is active cancer in them, but there has been cancer in them in the past. And she had multiple pelvic metastases. One particular new one was this fracture line. I don't know how well you can see it, but there is a fracture line. This should be continued, and there is discontinuation there. And that was new compared to her prior imaging. She had a very distinct focal area of tenderness there. So we knew that this is new. She is debilitated because of that. And the exam and imaging matched perfectly, okay? She was barely able, essentially pretty much bedbound at the point I met her in the hospital. She was admitted. She was telling me that any movement, even going to the bathroom, is impossible for her because of how severe the pain was. They were giving her continuous IV pain meds just to control her pain. So she was essentially inpatient pretty much for pain control, which is not, even if somebody has advanced cancer like this, they should be able to live a dignified life. They don't deserve just to be bound in the hospital if all they have is pain. And to find a solution for these, it becomes somewhat challenging. For her, we brought her in. Again, you can see that we have, again, that's what I'm talking about. So we have to find a way to access it in a safe manner. And these are blood vessels there, okay? So the whole point of doing image-guided, minimally invasive procedures is to get there in a safe manner. We got there, this is the ablation probe, the radiofrequency probe. We burnt the tumor there and we filled it with some cement. Some of it got up, but that's acceptable. It's within the range that I don't think it's going to hamper her performance. And she was essentially discharged 2 days after procedure with oral and pain meds and patch, which is a huge upgrade for her. The fact that she could perform her activities of daily living with assist on day one, that was the most elated this lady was in the 2 weeks that she was admitted. And we saw that this cement was quite stable on the subsequent imaging. So it stayed where it was, which is typically what we expected to do. So with that, I'm going to try to wrap up my conversation. So I think we're looking at a lot of good options for treatment of cancer in bone at the University of Minnesota. We are combining different therapies. It's not just this or that. We're not saying, say, ablation is going to replace radiation or radiation is doing that. What we believe in is that we are coming up with how we can maximize the benefit for each of our patients with a hybrid approach. We are combining ablation with immunotherapy in some of our trials. We're actually opening a randomized clinical trial to prove the fact that to get the best outcome, for example, in a spinal metastatic disease in select cases, obviously, not every case, but many of the cases, the best approach is to combine the radiation, external radiation, and percutaneous ablation and augmentation, because one of them, the ablation and augmentation, relieves the pain nearly immediately, gives mechanical stability, and when you combine that with a more comprehensive radiation that controls the local disease, it can result in better patient outcomes. The other thing that we do is we are using AI-driven targeting and planning. We are actually working on a very large registry with Institution for Health Informatics at the University of Minnesota, and that is to come up with the prediction factors of which one of the patients that is on, for example, on immune checkpoint inhibitors that has certain bone lesions are the ones that are going to go ahead and develop fracture in the future. And so we can get ahead of it and treat them at an earlier stage. If we come up with the predictive model to say, which one of these are the bone lesions that are going to cause trouble in the future, then we have an advantage over the cancer. And before the patient is too far gone, or the lesion is too big, or it's hard to treat, or requires a big surgery, we can hit it hard at the beginning and keep it at a bay. So that's one of the things that we are doing. We are using advanced imaging techniques for guidance of our treatment. And we are participating in many national registries and clinical trials, both inside the university with other, stakeholders such as oncology, such as medical oncology, radiation oncology, orthopedic oncology. We have a very large group of multidisciplinary group of physicians who are for treating these types of cancers, and we are very, very collaborative here at the university, and we partake in each other's trials. So with that, I want to thank you for your attention, and here's my contact in case you have any questions for me, and also my admin coordinator that essentially is going to help with any access need you guys might have. I'm going to stop sharing my screen now and open let you take over if that's okay.
Thank you so much, Dr. Talaie, for that incredibly rich and informative presentation. And I learned so much. The comprehensive look in the landscape of bone cancer that you presented, from how it presents in the clinic, the treatment strategies, and the promising emerging research that's happening at the University of Minnesota and beyond, is helping shape the future of care. So thank you for that. So now we will move into our Q&A for the remainder of the hour. So this is now your opportunity to submit any questions that you have with a leading expert in the field. And while folks are thinking about their questions, we already know for folks who have attended past fireside chats, it is not a fireside chat discussion without getting our virtual fire started to set the mood for our conversation. So while folks are thinking, I'm gonna go ahead and kick us off. We already had a few questions that were submitted in actually the registration, and a lot of the questions were around some of the secondary cancers and kind of why a lot of the secondary cancers we see from breast, prostate, and lung spread to the bone. Can you tell us why these specific cancers end up metastasizing to the bone, and what makes the bone such a common site for these secondary cancers?
Sure. So there are a few factors that play into it, and simply put, it has to do with how the signaling between cells work, how the circulation of the blood works, and what kind of environment is a good host for a cell or for a group of cells that have been separated from the origin, deposit of the tumor, and then they have certain receptors that allows them to engage and start growing into an area. Okay, so those are the factors that allow a deposit of the cancer to form, for example, in liver in certain cancers and in some other cancers in the bone. Again, the fact that certain pathways, for example, in the body facilitate metastatic extension. For example, if you have colorectal cancer, the way the circulation works is that it's going to allow those cancer cells to have specific access to the liver if you have colorectal cancer, because the blood flow that leaves that area ends up in the liver, and then there you can have a deposit, particularly if those receptors match perfectly. Okay. On the other hand, a lot of these other cancers, the outflow of prostate and breast is going to starting to circulate systemically. We have a very, very rich area of vascular supply that goes through our bones, plus some of those other qualities that allows capturing of those essentially and wandering around kind of deposits of groups of cells, and eventually for them to be deposited in the bone. And if you look at the bone, there are hypotheses for why, for example, spine is more common. Does it have to do with the particular circulation of it? Does it have with other factors into it? It's actually a question we are also asking ourselves, why it's certain tendency there. And those are some of the answers that we have come up with.
And I know that there is research happening at the university around just the seed and soil hypothesis, the tumor microenvironment that also allows some of these secondary tumors to thrive in similar environment from the primary cancer. So I know there's fascinating research about that. That was really helpful. So thank you for breaking that down. I think this leads naturally into the next question that we got. So from a clinical perspective, how do you typically then identify when a cancer that's started elsewhere has metastasized to the bone? So like what are some of the signs, symptoms, imaging findings that lead to the diagnosis?
Sure, very good question. So one of the most common way that we detect distant disease um, is when they're asymptomatic. So we are hoping that we can detect them before they become symptomatic, because often by the time they're symptomatic, they're rather large and consequential. So one of the things that happens for patients that are diagnosed with a cancer for any reason is they undergo staging scanning, and that can be with different modalities such as CT scans, MRIs, and or PET-CT. And one of the things we do in this staging is we review the bones with a very, very fine comb. People who stage the cancer, one of the biggest tasks they have is to look at the bones very specifically and detect any deposits. And then cancer in bone can have, particularly secondary cancer, can have different appearances, right? So sometimes they look at it as a focus of a sclerosis, like very dense calcium material, okay? That's one of the reactions that certain cancers cause in the bone. For example, frequently prostatitis like that. Breast cancer can be like that, but for example, lung cancer or kidney cancer, when they go to the bone, they take a bite out of the bone. You see what is lytic, essentially an absence, a vacancy, effectively soft tissue replacing the bone. And breast can also look like that sometimes, okay? It has the tendency to look like both, actually, breast specifically. But we have two broad categories of appearance of these metastatic deposits in the bone. Either they look plastic or sclerotic or lytic, and essentially like an absence of bone. And that's something a radiologist looks for every time a cancer patient has a scan. There are dedicated bone studies too, such as a bone scan, it's a nuclear medicine scan that we perform. That also allows us to detect, areas of activity, although that doesn't exactly tell us if it's malignant or benign, but in the context of somebody having a malignancy, that makes us alert. And sometimes, not always, but sometimes we biopsy these. Okay, image-guided biopsies are a big part of what I do, and many of them are done for either primary or secondary bone cancers. We use the CT scanner, same thing that was used to detect a lesion, to navigate a needle and place it in there and sample it and then send it for analysis. So that's how we confirm that cancer, that deposit, if it's not clear for us based on the imaging, we confirm it's actually cancer and what type of cancer that is.
Yeah, that's really helpful. So another question here is around treatment for bone cancer and some of the side effects that present. I know you kind of touched on the different the IR techniques, so interventional radiology treatments, but what are some of the common side effects with some of these treatments, and does it affect how somebody walks and moves? I know you said that typically with the IR techniques, pain relief is immediate. Are there any other common side effects based on some of the other treatments?
Sure. So there is nothing we do that is perfect. That's just the reality of medicine. There's no perfect solution for almost anything. It's all about balancing the risk benefits and the specific needs of the patient. So there's no solution for all problems. One solution at least. So what we do in IR, essentially, we advance the needle in human body, right? So right there, you're driving a sharp object in human body. Does it have a risk of bleeding? For sure. Is it less than if you were doing a big cut in the body? probably, okay? So bleeding is one of the potential complications. So knowing the vascular anatomy and avoiding those blood vessels, as I did show you, becomes very, very important. As you are advancing this needle, for example, to the bone, okay, you can cause a fracture right there, because these are not the healthiest of bones. So knowing what kind of device to use and how much force to use to get to the bone is also important. When you ablate the thermal injury, if you have a critical structure such as a nerve or skin or bowel or other spinal cord, so the thermal injury to those structures can be important. That's why you have to have predictive models of how exactly the thermal, the ball of heat or cold, whichever one you're using, is going to grow and what structures is it going to affect. So to minimize the injury risk. And lastly, when you inject cement, you need to see exactly where it's going. If you don't, when I showed you an example, there was a little bit of a streak going out, right? So if you don't stop it right there and then, it's going to continue to go out and becomes a problem. So controlling the cement and making sure it remains in the place you want to remain within becomes also important. So I think those are some of the main ones that comes to my mind at the time being.
It's fascinating. Thank you for that. So switching gears a little bit, we had a question that was submitted. Is there evidence linking PFAS, the forever chemicals, to bone cancer?
Not that I know. Not that I'm not implying that there is no evidence, but I'm unaware of it. Okay, if somebody has something that they are specifically aware, I'm happy to look into it and answer their question, but I'm unaware of it.
I know there's a study here at the university, the 10,000 family study, that's kind of looking at what some of those environmental exposures and how they impact cancer risk. So I know that there's some of that research that's happening here at the University of Minnesota. Okay, so switching gears a little bit on risk factors. So are there certain genetic mutations or syndromes that increase the risk of bone cancer?
Absolutely, there are some. I'm not gonna spout out some other names, but yes, there are genetic predispositions to both primary and secondary. So yes.
Okay, and then a follow-up question, is there anything people can do to prevent cancer? So are there any lifestyle modifications that they can do?
So when you talk about very rare diseases such as primary bone cancer, it becomes very hard to give a specific advice what to do to avoid it because we just don't know enough about it, right? So if you talk about primary bone cancer, it would become very, very difficult. But then if you're talking about secondary, then anything that can mitigate the risk of, having other solid organ tumors becomes very valuable. Things such as screening, such as, again, lifestyle modification, things that as far as, controlling the, metabolic state of our bodies, studies are out there that are suggesting that if you have insulin resistance, you have increased risk of developing cancers. Of course, healthy life habits such as exercise, certain types of diet are shown to reduce the chance of acquiring cancer. And again, then we are talking about the collective. It's very hard to predict the outcome for the individual. You might have the worst of genes, unfortunately, and despite all your healthy lifestyle, you develop a cancer at a very rare cancer at a very early age. But that's an anecdote. Nobody can build science off of one example. So we need abundance of participation in all these trials that we're talking to learn about them. And again, we have quite a few of those examples. But just to recap, for very rare cancers, it's very, very hard to predict, how to avoid them. For more common cancers, the ones that we all have heard about, there are many things that one can do between the lifestyle and the screening and, things of that nature.
So another question touching on the risk factors. So can injuries like broken bones increase the risk of getting bone cancer later on?
Not directly. So, if you have a fracture when you're like 15 because you had a skiing accident, I don't think you're particularly at high risk of there are things that can go along with it that eventually, if you want to look at it from a very complex lens, but simply answering that, no.
I think we probably need more studies to be able to
Yeah.
make a conclusive determination whether it increases risk or not. So looking ahead, Dr. Talaie, in your opinion, what are some of the most promising innovations and techniques in development for diagnosing and treating bone tumors?
So I think, as I was saying, using essentially big data and artificial intelligence is going to be extremely helpful. We are working on a actually, we are the pilot project specifically of in Institution for Health Informatics, and they have recently hired a specialist that is looking at imaging informatics, and we're trying to come up with the $1 million, answer of predicting which one of these patients with what features and in their lesion and or their underlying disease are the ones that need our attention immediately, even before they have a fracture. So, for those who are affected by it, we are trying to essentially create a lead time over cancer that is in the bone already, but we may not acknowledge it, we may not detect it, or even if we see it, we don't think it's as important, okay? So we're trying to essentially stratify these patients and find out who needs attention, who needs what kind of treatment. And again, that's only something that we can extract from large quantities of data. And we are doing that at the university. I'm very excited about that actually as a research. And then I think the fact that we are combining different modalities in terms of controlling the symptoms and improving the oncological control is another thing that I'm very excited. I think the hybrid approach and minimally invasive approaches are a wave of the future. I think the precision that we can achieve with those techniques is what's going to separate us, from treatments that were being performed in the past.
Thank you so much. That's really exciting to hear. So we're reaching the end of our time. So one final question to close us out. Dr. Talaie, what is one key takeaway you hope our audience leaves with today?
I think the biggest thing I'm hoping for everybody to take away is that we haven't arrived at the time or the stage that we can fully cure the cancer. Okay, we are quite aware of that, but I think in university interventional radiology and as a whole in our collective community at the university, we have come up with an extremely high number of ways of coping and adjusting the lifestyle that goes on with cancer. So cancer survivorship is a more pleasant experience, a more dignified experience for everybody who's suffering from it. We know it's a burden, but I think we have an abundance of essentially options that can help people live not only longer, but also a higher quality life with cancer at this point.
Amazing. So thank you so much, Dr. Talaie, for sharing your time and your expertise with us today. I mean, your insights truly deepen our understanding of bone cancer, bone in the cancer, and also highlight the importance of research and care in advancing this field. So we're so grateful for the impact you're making, not just here in Minnesota, but beyond. And thank you to all of you who joined us today for showing up, learning, engaging, and for helping us raise awareness. So please take this opportunity to continue the conversation, whether it's by sharing what you learned today, encouraging a loved one to seek care for persistent pain symptoms that they're experiencing, or supporting the research that's driving hope forward. Before you go, please take a few moments to fill out a brief survey that will pop up on your screen as soon as the Zoom ends, and it will also be shared in an email that will be sent out tomorrow. Your feedback truly helps us improve future fireside chats, and once you submit the survey as a token of appreciation for your time, you will be able to enter a drawing for some goodies from the Masonic Cancer Center. And make sure to mark your calendars for our next fireside chat on Wednesday, August 20th, same time and place. And so if today's conversation sparked your curiosity on how and why cancer spreads, during next month fireside chat, we'll actually be diving into that. We'll be uncovering the hidden steps of how cancer spreads, what we're learning and why it matters. So it's going to be a really fascinating look into the science of metastasis and what researchers are discovering that could shape the future of cancer care. The registration details will also be shared in tomorrow's email, so make sure you keep an eye out. And lastly, follow the Masonic Cancer Center on all of our social media platforms to stay up to date on future announcements and updates from the Masonic Cancer Center's Office of Community Outreach and Engagement. Until next time, thank you everyone. Take care. Bye now.
Thank you very much. Thank you.
You're welcome.
Yeah.
Bye, Dr. Talaie. Appreciate you.